Hello, we are live now.
Yeah.
Can you hear?
Yeah. The PCOS Society of India welcomes you to the second online workshop on improving pregnancy success in PCOS. I would now request Dr. Dhuru Shah, our president, to give a welcome address. She is the director of the Gynae World, the Center for Women's Health and Fertility, Mumbai. She is the founder president of the PCOS Society India and a founder trustee of Women's Empowerment Foundation. She is also the trustee and past president of the Mumbai OBGYN Society and the past president of ISAR, FOXY, and Indian Menopause Society. She is the chair for the special interest group of on reproductive endocrinology and PCOS at Aspire, and an international advisor for the special interest group of ESHRE. She is also the chair for the Indian Special Interest Group, American Society for Reproductive Medicine, and she has been the past director of digital education, International Menopause Society. She's also been the past chair of the Indian College of Obstetrics and Gynecology, which is affiliated to the Federation of Obstetrics and Gynecological Societies of India. She is the honorary fellow of the Royal College of Obstetrics and Gynecology, and she is the first and the only Indian to receive the FIGO Distinguished Merit Award for her services towards women's health. Dr. Dhuru Shah, please.
Good afternoon, ladies and gentlemen. Thank you very much for being part of our program today. I welcome you all to this workshop which we have planned for you, and the workshop was originally meant to be along with the conference which we were supposed to host in the month of November. Unfortunately, the conference has been converted to a virtual meeting, and we had 4 pre-congress workshops which we were planning to do a day before the conference. Since it's a virtual program, we thought it would be wise for us to separate out those 4 workshops and complete them on other days as webinars. We finished the first workshop about 2 weeks ago, and that was on induction of ovulation in PCOS. And now we are talking about assisted reproduction and how we can improve and optimize our pregnancy rates. So today's program will be starting soon in another few minutes. And whilst we look at the program and see that we have a large number of international speakers in today's program, it will be basically consisting of a few lectures followed by a lot of discussion. As usual with the PCOS Society of India, our programs are all very highly academic, followed by a lot of discussion, which I think is very, very important for the delegates who attend our meeting and make it worthwhile for them. Besides this, these free workshops which we are doing, we are also doing various other programs, and I'd like to take this opportunity to talk a little bit about them. We are conducting a quiz which is called the PCOS Quizzes, and it's a weekly program which will run for about 16 weeks. It has been initiated on the 15th of August. And that program is a program wherein everyone can participate. But the final round of the quiz, and you know, when you participate in this quiz, there is a multiple choice question answer, and when you answer it and you tick on the answer which you think is right, if it's correct, it gives you 5 points. And if it's not correct, then you will be told that this is the wrong answer, and the correct answer will be given to you so that you've understood the subject right there. It's very educative. So we've been running this every week, and all our members from our PCOS Society committee have been participating and putting up these questions, which both the quiz has been convened by Madhuri and myself, and we have various coordinators who have helped us in putting up a quiz every time. The final round of the quiz will be held after 16 weeks, and that will be with a lot of prizes which will be won, but those that final round will be open to the members of the PCOS Society. Though everyone is participating in this quiz and everybody is learning from it, we are very happy to do so, but the final quiz, which is the first prize of 1 lakh rupees, is open to the members of the PCOS Society. The second very good program we have started, this is the month of September. This is our PCOS Awareness Month. And we have started YouTube videos. The first video has just been released. And it's on YouTube and through the PCOS Society of India. So watch out for it. We will have a video up for you every 15 days. And this is meant for patients, which you can share with them. The third one is the PCOS Science Live, which is going to be initiated this month. And that is, running through the life of one of our, great achievers in the field of OBGYN. And we'll be covering one person, one individual every month. The first one we start with Dr. Praveen Matre, who will tell us his journey through all the research he has done, being the person who's done the world's first ovarian transplant. So he's done much more, and we will be chatting with him to know how to go ahead. And this program is mainly associated with learning how to do research. It's targeted more to people who are interested in research and understand how you go about it and how you proceed. So these are the three great programs which you've initiated now. But of course, our Pandora, our newsletter continues. Our conference will be in November, and I'm sure Madhuri will give you more details on that. And since it was to be held in Bangalore, Madhuri was the convener for that program. And that program we are looking forward to. That will be a 2-day virtual program, again, virtual, converted to virtual. So let's go ahead with today's program, and I'll request Madhuri to introduce our first speaker, and then we'll go ahead with the program. Thank you so much.
Yeah. So today, our first speaker is none other than Dr. Louise Hull. She's the Associate Professor at the University of Adelaide, Melbourne in Australia. She leads the Endometriosis Group and Fertility and Conception team at the Robinson Institute. She's also the medical she's in the medical advisory committee of the Aspires Australian country, and she's also the Aspires Australian country representative. She co-chairs the special interest group on implantation at Aspire. She is an international ambassador to the World Endometriosis Society, and she is a treasurer of ANZ CREI. She also chairs the Aegis Grant Committee, and she has been the past associate editor of Human Reproduction. Her areas of research are basic sciences, digital technologies, and clinical translation in endometriosis, implantation disorders, and miscarriage. She supervises the PhD students and teaches reproductive medicine to medical students, registrars, and reproductive medicine fellows. She has received numerous grants, fellowships, and awards. Today, she will be speaking to us on controlled ovarian stimulation in hypogonadotropic hypogonadism with polycystic ovarian morphology.
Thank you so much, Madhuri and Duru, for that kind introduction and for the honour of being able to speak to what is a very well recognised society around the world, and I really appreciate it. I'll just share my screen and just set everything up and make sure everything's working. But the talk I've been asked to talk on today, and hopefully this will work. Does that look fine?
Yes, it's fine.
The talk I've been asked to talk on is controlled ovarian hyperstimulation and hypogonadotropic hypogonadotrophism in women with polycystic ovarian morphology. And that's just an introduction for me. But the main things I want to talk about today, I'm just going to briefly go through the outline of the definitions of both hypo and also polycystic ovarian morphology, and what the underlying pathophysiology of them a little bit. I also then want to look at the causes and how you really establish a diagnosis. And this diagnosis, it's a very heterogeneous group of conditions that are not, each one in itself is not commonly seen. So it is really important to get a diagnosis. But also in this condition, inducing ovulation can be quite tricky. And there are things you have to think of that are outside the way we induce ovulation with PCOS. And so I'll talk a little bit about ovulation and just also put some tips and things that you can do to help couples who have hypo. So firstly, when we look at the definitions of hypothalamic hypogonadotrophism, they're relatively broad definitions, basically saying that there's absent ovarian function and that this is due to abnormal pituitary gonadotrophin levels. So essentially, FSH and LH are not driving the ovary to make eggs. And that can be due to an absent or inadequate hypothalamic secretion or failure of the pituitary gonadotrophin secretion. So it can be at the level of the hypothalamus here and the signaling here, or it can also be lack of release from the pituitary here, and the ovary doesn't get stimulated. Just to clarify where the WHO criteria fit in here, this is WHO anovulation 1, although I've also snuck in hyperprolactinemia into this talk. It essentially is a relatively rare condition. It's about 5 to 10% of anovulatory women, but it responds quite differently to PCOS. And it's hypogonadotropic hypogonadotrophism, which means low estrogen levels and low FSH levels. But also it can be hypothalamic in origin, so hypothalamic amenorrhea, or hypopituitarism. So again, it's at that level. And the main issue is it's associated with estrogen deficiency, and we do have to be aware of that in terms of long-term bone and cardiovascular health. The reason people with polycystic, with hypo have a polycystic ovarian morphology, and you can see the morphology here with lots of follicles, but you'll note that the stroma isn't quite so thick as you would see with PCOS. And the main issue is in the first initial preantral follicles, AMH controls their development so that you don't have all your eggs developing at the same time. And usually when you get to this antral phase, FSH is required to then start the production of estrogen. And in hypothalamic hypogonadotrophism, you have normal androgens, but low FSH, normal or low androgens, low FSH, and normal or low LH. And what we see is that we just don't have FSH to drive the follicles into an antral phase. So you end up having all these small follicles left at this position. This is different to PCOS. The main issue with PCOS is because LH is very high and androgens are high, you end up with a very high AMH, and that prevents the FSH action driving the follicles into the antral phase. And you see different features where the follicles around the outside with a very thick stroma that the thecal cells are in. And so there's slightly different features. So is it important to determine the underlying pathophysiology of hypothalamic hypogonadotrophism? And it really is, because there are so many different reasons you can get it, and you would treat them slightly differently, particularly before ovulation induction. Firstly, there are some genetic causes. And in these conditions, often puberty is delayed. So people will make the diagnosis of these conditions when children are quite young, and they won't go through puberty. So we'll see it at 16 or 18. And sometimes you can see it before then, and I'll explain why in a minute. But about 30 to 40% have genetic mutations that alter the migration or function of the GnRH neurons. And some of the time, so the GnRH neurons migrate in the same pathway as the neurons for smell. And about 40 to 50% of the time, the smell is intact. So that's particularly if it's a mutation in the KIS protein or KIS receptor or the GnRH receptors. But about 50 to 60% of the time, there's also anosmia, which means that patients can't smell. And that's a real clue that they may have Kalman's syndrome. A lot of Kalman syndrome are on the X chromosome, so men get affected by it much more than women. But I have looked after a female patient who had 2 mutations that affected Kalman syndrome on the X chromosome. So it is possible, but rare to see in women. And she was diagnosed when her jersey caught fire, and she actually got a burn because she couldn't smell the fire. And she was diagnosed when she was quite young. And because of that, she was appropriately given pubertal induction. But when she wanted to have children, she knew she had to see a reproductive endocrinologist, and we induced ovulation at that stage. And there are several genes that affect Kalman syndrome. It can be diagnosed on MRIs because you can see there's a different migration pattern of the cribriform plate where the neurons for smell travel to. And you can see that on MRIs. There are some genetic conditions that can be either normosmic or anosmic. So sometimes you can't tell. And the geneticist now would run a screen if we have someone with delayed puberty that we think is due to hypo. You can also get tumours of the pituitary and hypothalamus, and these are quite important to diagnose because obviously they can have a real impact, particularly on the optic nerve. And if the pituitary gets expanded, it pushes on the optic nerve, and you can get visual defects that can obviously be permanent if there's a tumour there that's a problem. And so if you suspect a pituitary problem, you really do need to do a physical and look for neurological findings like visual fields, headaches, galactorrhea. And we would then assess the pituitary profile, looking at FSH, LH, checking estrogen, prolactin, TSH, and for other very rare tumours like ACTH secreting tumours, you check a midnight salivary cortisol, or for growth hormone, you would check an IGF-1. And for these 2 conditions, usually there are other stigmata of Cushing's or acromegaly. We would normally do an MRI of the hypothalamus and pituitary to assess that, and that's how you would make the diagnosis. And by far the most common tumour in the pituitary is a prolactin secreting adenoma or prolactinoma. And usually, as long as it's under about 3 centimetres, it's a matter of treating with carbergoline and reducing the levels. And usually the prolactin's over 1,000 if we need to treat it. However, should someone become pregnant, you do have to monitor visual fields so that so it doesn't grow in pregnancy and then affect the optic nerve. Other tumours can be found, and in that situation, you really do need to consult neurosurgeons or endocrinologists. And there are other conditions like Sheehan syndrome or empty cellar syndrome, where the pituitary is not functional, and that usually is diagnosed at an MRI. Or there's a history of amenorrhea after breastfeeding and of significant blood loss at delivery, or in another accident or something like that, that's affected the vascular supply to the pituitary in Sheehan syndrome. But those conditions are very rare. By far, much more commonly, we see conditions that affect the secretion of the hypothalamus, and that's basically by suppressing the hypothalamic pulsatile secretion of GnRH when the body gets very stressed. And usually the main 3 conditions are situations where caloric intake is very low, and quite often there's a diagnosis of anorexia or bulimia. And people with these conditions really do need quite a lot they need to have a proper diagnosis and then get to the right services to help them, because this is quite a significant condition for young people to suffer, and you do need to get the right services and also look at nutritional support. Anorexia is also quite difficult to manage in pregnancy, and people's body image is affected by pregnancy, and often it's quite hard to get people with these conditions to maintain their caloric input. So it's really important that you work that through before you start. Another a common reason for amenorrhea and hypothalamic hypogonadotrophism is at high-level athletes, where people do lots and lots of exercise and their caloric input is really only just meeting their needs, and they want to have a lean body mass because it helps them achieve in their professional careers and in their sport. We would be encouraging them to take a little bit of a step back on exercise, look very closely at their nutrition, and increase their caloric intake before attempting pregnancy. Probably the most common is chronic stress and depression. And we see very commonly around exams, or when people are doing fertility treatment, or when people have had miscarriages, we find that temporarily the hypothalamic function is suppressed to really protect them from a pregnancy when the world has just got too much. Often once they've finished their exams, you know, a few months later, when they've been able to grieve for that loss and miscarriage, and with the right support, their periods will recover, and that's often quite temporary, although sometimes people need support and help actually inducing ovulation. There are some other medications that will affect hypothalamic function, and it's really important to recognise what they are and understand what they are. But most of these medications you would really need to only withdraw with medical support and with people who really know what they're doing. Because if you, I'm so sorry, I'll just go back. With resveratrol, it's a antipsychotic. So if you it elevates prolactin levels and will suppress ovulation and suppress FSH and LH secretion. But if you withdraw it, people can become psychiatrically unwell. If people are addicted to oxycodone or opiates, it suppresses GnRH secretion, but you will get withdrawal from if you stop it, and you do need to manage that properly. And prednisone is the same. You can, obviously, if you're taking prednisone and have been taking it for a long time, you can get an Addisonian crisis if you withdraw it, and that reduces GnRH synthesis. Another cause of hypo is undiagnosed medical conditions. And what we find is that if people are medically unwell, their hypothalamus won't function properly. And I certainly have had patients with polycystic kidneys and chronic renal problems, inflammatory bowel disease. I've had a patient with a mitochondrial disorder who couldn't generate enough energy to keep her energy requirements up so that she could ovulate. And just this week, I've actually had someone who became amenorrheic just in the last wee while, and she had a very low white count. And we've actually diagnosed cytomegalovirus. So we're going to wait till she recovers from that. And I think her periods will come back to normal. But hemochromatosis, you can get deposition of the heme in the pituitary, and thalassemia can also be affected, and cardiac disease as well. And all of these conditions need to be diagnosed, but also they need to be treated. And you need to get obstetric physicians to assess whether it's actually safe to carry a pregnancy, or whether a pregnancy is really going to be too high risk for someone, and that they might need surrogacy or another way of having a child. One of the issues that we see, and I do quite a bit of adolescent gynae as well, is that when girls don't go through puberty and they need pubertal induction, sometimes you can get the pubertal breast changes and changes in hair growth and all the other pubertal changes, and light periods, but the uterus can still be quite small. And I have certainly seen someone with hypo who was actually diagnosed as not having a uterus because they only had a transabdominal scan, and the uterus is really quite small when it's prepubertal. And she was told she actually had Rokitansky syndrome, which is absence of a uterus, because the uterus was really quite small and tubular. And in a prepubertal uterus, the cervix is very long compared to the body of the uterus, and it can be quite subtle, and some sonographers who are not experienced at gynae can miss it. And she found it very hard to go to a doctor till she was about 24. And when we actually did some scanning and confirmed there was a uterus, she had been thought all her life she didn't have a uterus. And we gave her estrogen and grew the uterus, and she went on to have ovulation induction and carried a baby to term. So sometimes you do need to supplement a little bit more, but even when the uterus is small with ovulation induction, you can achieve a pregnancy, and the womb will grow in pregnancy. So it doesn't have to be, it can be a little bit small. So I'll move on to how to induce ovulation induction. And the first question is it worth thinking about using things like Letrozole or Clomid for OI and hypo-hypo? I also am going to talk a little bit about how to undertake it and what strategies you can use with FSH and LH ovulation induction, what the risks are of ovulation induction with FSH and LH, and also what to do if it's a real struggle to get monofollicular ovulation when you're doing ovulation induction with hypo-hypo. So the first question is, will Letrozole or Clomid work in hypo-hypo? And there's some caveats on this, but some of the time it does. So especially in conditions where FSH and LH production and release is not completely suppressed. So for example, in people with medical conditions, they still will produce FSH and LH when they become in better health. Some of the high-level athletes, if they reduce their exercise, people who have low caloric intake, you can sometimes get ovulation if you use Clomid and Letrozole, and sometimes it's worth trying in conditions where you know that FSH and LH are not completely suppressed. And that's because, and Letrozole works, as you all know, by inhibiting estradiol's negative feedback on the pituitary, and that promotes the release of FSH. GnRH pumps are in the literature. There's quite a lot of information on it. It's mainly from the 90s. Generally, these are not available in a lot of places, and certainly it's not possible to get GnRH pumps in Australia. I think that's the case in India, but you have to have an intact pituitary. You start at 15 micrograms and then use 5 microgram increments. And it may take a little while to get it going because you need to get, you need to prime the pituitary. And the main reason people used to use them is that there's a very low risk of having too many follicles. The problem is they're expensive and very difficult to get. But I do know there is a Japanese company that do make them, but it's not something we would routinely use. I'm sorry, I'll just cough for 1 minute and I'll just mute myself. So coming to what we actually do, there are several medications for hypo-hypo, and it's really important to understand the physiology because LH and FSH are not present, which is much different to people with PCOS who have high LH levels. And LH is required in the thecal cells, in the early follicles, to convert the cholesterol base to progesterone. and LH does that in the thecal cells. And after you have the androgens that are produced by the thecal cells, you then need LH and FSH to aromatize them to make estrogen. So if you don't have either LH or FSH, you might use FSH, but you won't be able to get a lot of estrogen around because you won't have the building blocks of androgen. And so we generally look at using human menopausal gonadotropin, which has FSH and LH in a 1-to-1 ratio, and so it's one injection. We can also use Pergoveris, which is recombinant FSH and LH, and that's in a 2-to-1 ratio. And then quite commonly we use FSH with HCG, and HCG is essentially a long-acting LH. And that's usually the most cost-effective way. There are various different protocols, but initially we start on a low dose, and if it's FSH, it's 25 to 50. HMG often at 75. And then we scan a few days later to adjust the dose. Now, it's absolutely critical to have close monitoring because FSH is a very powerful medication, and you can often get more than one egg develop if you don't get the dose right. So it's not like Clomid and Letrozole where you can give the tablets and check a wee while later. And as long as you know that they're ovulating, often you can check a few months down the track or use just day 21 progesterones. With FSH, you really do need to do scanning and blood tests, and it's a lot more involved. The other thing is in hypo, you won't have an LH surge. So you do have to use an HCG trigger and also potentially some luteal support because they won't be getting LH from the pituitary. And what we would look to do is use a low dose and have a look and see if any eggs are developing 6 days later. If that's not happening, we increase the dose a little bit and have a look. And if we start to see an egg developing, but it's still not growing quickly, we might just increase the dose a tiny bit and hopefully get this one dominant follicle. And the idea is to get one dominant follicle and then to trigger its release. And for a couple that has never had the possibility of pregnancy because they've never had an egg being released before, quite often we would expect, provided the sperm count's normal and that we know the fallopian tubes are working, there's really quite a high rate of pregnancy. And in this review, they've reviewed about 15 different studies, and the pregnancy rates are high with both HMG and FSH and HCG, and around 90% over 6 months. So it works very well, and usually the egg quality is good, and obviously the sperm quality has to be good and the tubes have to be working. But usually the main reason these couples aren't conceiving is that they've just never seen an egg to try and conceive with. There are risks, and it really happens quite commonly that you will either get no response whatsoever, and then when you get to the threshold in the dose, suddenly you've got 10 follicles. And that's quite a common thing that is very frustrating for people because often you creep the dose up over quite a long time, and then you end up having to cancel and telling people to try and use contraception to avoid a multiple pregnancy. And that's a significant risk in FSH ovulation induction. You can either trigger or you can wait for the follicles to resorb and start again lower and slower. Ovarian hyperstimulation can occur, but it's not very common because people bail out of cycles when they start to see too many eggs grow. But it is possible, and essentially you wouldn't trigger if you thought a hyperstim was going to occur. And that would prevent the vascular infiltration of the corpus luteum. Multiple pregnancy is a complication, and in the 90s, and these are older studies, they were suggesting it was up to 30%. Certainly, we have had a twin pregnancy, in a person with hypo with ovulation induction. And if you have high order multiples, you can consider fetal reduction, but that's a terrible thing for people wanting fertility to go through. And also you need high-risk pregnancy care. So it's really important to try and avoid that. One other option which I've found very, very helpful is if we are really struggling to get monofollicular stimulation of one egg, we start the FSH and we monitor very closely, and we have everything signed up for both going to IVF if there are a large number of follicles, or going to OI if there's only one. And usually there isn't going to be a natural LH surge. And although most of the time we'd probably start an antagonist if we were going to IVF, you know, generally you won't get premature ovulation if there's no LH coming from the pituitary, and that can work really well. So I'm going to give you a case just to try and explain that a little bit. So this is a couple that I saw, and she was 26 and he was 28, and they were really high-level track athletes. You know, they were, you know, planning to go to the Olympics and the Commonwealth Games, and were complete professionals, and their income was highly dependent on their ability to perform at a high level in athletics. They had been, it's quite a stressful life. They don't actually get very much money, and they did a lot of traveling because they had to go to meets all around the world. And they had got to the point where she had decided she wanted to take a step back from her training and focus on conception, and that would give him the opportunity to really focus on and provide an income for the family by training for international games that he wanted to go to. And they both trained each other too, so they actually were training each other as well. The history was that she had menarche and regular cycles at 16 years of age, but became amenorrheic at about 20, when she really was doing a large amount of exercise, somewhere between 2 and 6 hours a day. And she had a highly regulated diet that was put in place by her trainers and dietitians, which was healthy, but wasn't very high in carbs or calories. Her BMI was low at 18. And when you looked at her pituitary profile, her FSH was 1, her LH was 1, and her estrogen was 92. Her thyroid function and prolactin were normal, but her androgens were low, which is consistent with hypo. We did do an ultrasound, and the uterus was normal. She had a high antral follicle count of 23 and 27, and her AMH was 45, which was consistent with this. So we knew we had a lot of follicles. Her hemoglobin was a little bit low, and her other bloods were normal. And I found out that high-level athletes often have a little bit of leakage of hemoglobin into the gut, and also sometimes they break down blood cells in their feet when they run. He was in good health, and his sperm count was usually normal. However, it was interesting because I think he probably had some pituitary suppression, as if when he was training hard, sometimes the count dropped a little bit, both in motility and morphology. And both were very healthy. They didn't smoke. They couldn't take any kind of anabolic steroids or anything like that because they would be disqualified. And there was no question about their health. And so there's a condition that the Americans call female athlete Triad syndrome. And that's where you have low energy. And it's really more that your training puts you right on the edge of catabolism. You don't carry any extra calories, and you eat just as much as you use, or sometimes a little bit lower. Usually people are amenorrheic or have very prolonged cycles and have low estrogen as well, although the exercise often maintains bone mass to some extent. And this is what happened when we tried ovulation induction. So we agreed in between flying overseas that we would do an ovulation induction cycle. And we used FSH and HCG. And we started with 50 units. And when we had a look, really there was no stimulation. We hadn't reached the threshold. So we crept the dose up just a tiny little bit. And we got lots and lots and lots of follicles, and we just had to cancel. And it was a really all or nothing response. And this is really where you can really benefit from signing consents for both options. And so we decided to go into a lower dose and start a lot lower at 25. Again, we didn't really get a response. She had modified her diet and exercise a little bit more by the stage 2. And then we managed to reach the threshold when we got to 50, but we had too high a response for ovulation induction. And so we decided to move to IVF, went on to retrieve 16 eggs, 12 of them fertilized. And because we hadn't had too high a response, if we'd had 30 follicles, we would have had to not put them back and prevent ovarian hyperstimulation syndrome. And you have to be careful because we cannot use an agonist trigger. You have to use an HCG trigger because there's no LH that will be released. So you can't get out of hyperstim very easily. And we were able to use an HCG trigger. We had 16 eggs. One 4AA embryo was able to be transferred on day 5. We got 6 embryos frozen, and fortunately they had a positive HCG and went on to have a live birth, which worked really well. So in summary, hypo with PCOM is seen in about 5 to 10% of anovulatory women. It's really important to determine the cause and ensure the lifestyle and medical and genetic factors have been assessed and addressed. We usually need FSH and LH to induce ovulation, but occasionally Clomid and Letrozole will work. And generally we use step-up protocols and treatments with both gonadotrophins. The pregnancy rates are high when we do get ovulation, and they quoted as about 90% over 6 cycles of OI. And the multiple pregnancy rate can be high, so you do have to monitor very closely. And sometimes you do have to have a recourse to IVF, and that was the case in our case. So hopefully I've explained a bit about hypo with PCOM. I'd be delighted to take questions, and I'm just not sure what my timing's like here, so it might be at the end. But hopefully that's helped.
So if there are any questions, we'll take the questions now and then also at the end of the session. Any questions from the audience? You all can please type it in the question and Q&A box so that I'll receive them. Any questions, Sujata, Duru, Rekha?
Madhuri, it's not getting, it's not activated, that Q&A.
No,
so
I
have.
Type. I can't. No, I have a. No, you can just ask.
I can't type the question.
No, you can ask because I have another Q&A here for the audience. You can ask.
I'll type in the chat.
Okay. No, you can just
there are some hypoc patients who have low AMH.
That's yes, so that certainly can happen.
Can you hear me?
Where you get hypo and low AMH. And I think that sometimes there are 2 pathologies. So I have had a patient who had been diagnosed as a child when she didn't go through puberty.
Put it in the chat.
Huh? Can you hear me?
Yeah, we can hear you.
So I have had a patient who had a hypothalamic dysfunction diagnosed, and they actually did 10-minutely blood tests to check the wave of hypothalamic secretion in kind of the 90s and as a research project, and she really did not have an appropriate hypothalamic secretion. and didn't go through puberty. So they induced puberty, but then she also had secondarily had a very low ovarian reserve, and I think they were independent. And we couldn't work out what was going on because her FSH was quite high. It wasn't that, the FSH didn't correlate to the number of eggs at all. And we, so she had gone into she'd actually gone into premature ovarian failure, but because she wasn't secreting FSH and LH, they weren't high. They weren't over 20. They were sitting at about 8 or 9, but she didn't have any eggs. So she couldn't then push her FSH and LH up, and she was actually in ovarian failure and had a pituitary problem. And the only way we ended up being able to diagnose that was to actually try and induce stimulation of the ovary, and it just didn't work. So that was really tricky because her FSH levels were not high enough to diagnose premature ovarian failure, but she actually just didn't have any eggs in the ovary. You could not stimulate them. So it can be, I think there's probably an independent reason why the egg numbers are low.
Thank you.
Yeah. Guru?
I have a question. Which ones are you seeing more often? We don't see these cases very often, but in your area, do you see more of PCOS having hypo, or do you see the non-PCOS having hypo? Which are the common patients who come to you?
Yes, so we usually, I think PCOS people would be the most common, and then there are very clearly hypo patients, but we see some PCOS patients who've been usually diagnosed very early, and then they decide to diet and exercise to kind of prevent the symptoms of PCOS, usually as teenagers, and often they've had a very strict diet and exercise regimen to really try and prevent the symptoms of weight gain and, you know, hirsutism and things like that. I think they have a combination where they don't have a very easy pituitary response, but they also have, they don't really exhibit the metabolic issues, but they've really got PCOS. And they're very, very tricky to stimulate, really tricky. And you know, we often get either 0 and then they take a sniff of FSH or Clomid and they suddenly have 100, and they're probably the trickiest ones of because I think they've got both conditions and they've actually given themselves hypo.
But is the phenotype as obvious as it is in a PCO and a non-PCO patient who are not hypo, the ones who are with normal, pituitary hormones and high androgens, and women who are non-PCOS, we have a different picture in terms of the ovarian picture, the look, I mean, the hirsutism, etc., etc. So in these patients who are hypo, do you see a similar type of phenotype, or is it different?
It can be quite hard to tell. I think the things that I would be interested in your view on this actually, Drew, because you're probably more expert than I. The things that I think I find distinguish them are usually hyperinsulinism and metabolic problems. And acanthosis, and yeah, a little bit more hirsutism and things like that. So that's probably the thing I go to. It's a little bit tricky even when they're younger as well. I see a lot of adolescents, and I'm just not sure if it's hypo or PCOS, and sometimes you can't really formulate that diagnosis at that age. But I think if I think there's hyperinsulin there, I definitely lean towards PCOS. And sometimes the LH is just higher than the FSH, even though it's not diagnostic. That is a little bit of a heads up. So I think, what's your view, Drew?
Whatever I have seen of hypo PCOS have been lean girls. They tend to be more hirsute and yes, insulin resistant compared to the ones who have a normal FSH or maybe a raised LH or raised. but I see them more lean and more hirsute as compared to the other group. So that's what I see. I have one last curious question, something related to COVID. COVID patients are having loss of smell and loss of taste. Anything common between these patients? Do you think those neurons are getting affected? I don't know what it is. But patients with COVID today are having loss of smell.
It must be, so I would imagine the virus, it must affect the upper respiratory and lungs. And so probably the nasopharynx and where that cribriform plate is, you know, the cells in there are being destroyed by the virus, I presume. Yeah, I had never thought of that.
Luckily, it's not coming from the top. It's coming from below up. Anyway, that was a brilliant talk, Louise. Thank you so much.
No problem.
Yeah, thank you, Louis, for that brilliant talk. And in case it's not late for you, we would really love you to be there for the discussion at the end of the entire session.